All right, so what are your questions about F and E? All right, can you guys hear me? Because I can't hear anything. So I just need one person to say something. Okay, guys, so I've asked about 3 times. I'm still waiting for somebody to answer me. I don't know if you all can hear me or if I can hear you. So my mic is on, but I don't know if you guys can hear me. I need someone to respond, please. Okay, can you guys hear me now?
Yes.
This is hilarious. So Zoom has updated their product, which I find hella hilarious. And I've been sitting here like recording for the last 3 minutes saying, or actually longer, can you hear me? Can you hear me? I need somebody to hear me. What are your questions about fluid and electrolytes? And then I realized that I had to admit you guys to the room. I'm sitting here like, what are they doing? So the whole time it was me. I'm like, oh my freaking goodness. This is hilarious. So what are your questions about F and E? So where are your barriers? Where are you stuck?
For me, it's I guess like the hypovolemic and sorry, looking at my notes.
Okay.
Because from what I was looking at, the euvolemic, hypervolemic, and hypovolemic, that usually applies to the hyponatremia, correct?
That affects the sodium. And
Okay.
so we're going to either have sodium dilution or the things that we talked about.
Okay, gotcha. So I just wanted to make sure that it wasn't like across the board on all of the fluids, but that one just particularly pertains to sodium, correct?
Yeah, that's a sodium, and that's because of, and it may have some, there was a couple that also had potassium issues because of how it, you know, for example, the one where they, like if you're hazing and you make them drink a bunch of water. So that's going to dilute all of their electrolytes, not just the sodium electrolytes. So that,
Gotcha.
so when you're looking at the euvolemia, the hypovolemic, and then let me pull up the, let me share my whiteboard. Let me just do that. And that will probably help you at that
because time. For the euvolemic, that one, the water increases, but the sodium stays the same, correct? So then it basically gets diluted, which is why you don't get any swelling.
Right, everything that's happening is happening on the inside. So let's just review it so that way we're all on the same page.
Okay, thank you.
I'm going to share my screen and I'm going to go to the whiteboard. Here we go. Share screen. And I'm going to pick up the whiteboard here. All right, so you should see a whiteboard blue screen in the back. I'm going to make it a little bit bigger. Okay. So let me get my little brush, the one that I want. And I'm going to start with that color. All right, so when you have euvolemia, and U means normal, okay, way too fat. So when you're looking at euvolemic or euvolemic hyponatremia, you're looking at in the body, you have water that increases. You have an increase in water. But the sodium is the same. So that's what hyponatremia or low sodium, but the volume is normal. That's what that is, okay? All right. So there's no edema. There's no edema that's present. That's because the sodium is diluted. And the sodium is diluted secondary to an increase, oh, this is irritating. There, let's do that. And water volume. So that's your euvolemic hyponatremic. So that should be a C. Okay. So that's the deal there. when you have, and this is, you can see the euvolemic hyponatremia in your Siadh. I'm going to scroll down. So some of the causes of where you would see that would be in Siadh. And we see that because the ADH, the anti-diuretic hormone, it's increased. So we have an increase in ADH because, due to or secondary to an increase in secretion. And that ADH is being increased in the body. So it's causing the body to retain water. Therefore, if the water is being retained internally, your sodium is being what? Diluted. So the reason why it happens in DI is going to be related to the treatment. So, which is going to be the vasopressin. So when you take the vasopressin, it causes the sodium to lower. Okay. So that's how that particular portion happens. Does that make sense? Does that answer your question about that?
Yes.
All right. So I'm going to go and do the next one. Okay. So now when you're looking at hypovolemic, and this is going to be decreased sodium. Here, the patient is dehydrated. Okay, so they have lost both water and sodium. Where the other one, we didn't lose the sodium, but it's diluted. So think of causes to make you dehydrated. So your causes would be vomiting, diarrhea, NG suctioning, diuretic therapy. Oh, freeze frame, don't like that. What else? There's a couple more.
Burns.
Burns, and why burns? What's happening in burns? You're right about the burns.
You're having a shift in the fluid to interstitial spaces.
So right, there's a fluid shift. So shift in fluids, and it's going from the intravascular space, and intra just means inside. So inside the vascular space, and it's shifting out to the interstitial space. So that's why. So now we're losing both. So we don't have the volume because our volume is not in our vascular system. It's gone. But we also have low sodium because we don't have any volume, and usually sodium follows what?
Water.
Follows water. Okay. The other one would be excessive sweating. So an individual that has excessive sweat would be considered, that'll be another reason why you have a loss in both. So if you're outside working, construction workers, for example, or anyone that has a job that's outside in the elements versus, you know, the inside job with that nice AC blowing. All right, so the next one for which we'll talk about, that's the dehydration, would be hypervolemic and decreased sodium. So that's going to be the next one, but this is all related to sodium as a whole. So here we have hypervolemic or hypo, and we still have decreased sodium. So here, water and sodium are both increased. And this is going to lead to volume overload. So the reason why is the total body of water and sodium are regulated independently. So when you end up with the overload, then the sodium becomes diluted. So because of the overload component, this is going to dilute the sodium levels. And this is going to lead to edema. But they're not moving together, they're independent. Patients that you usually see this in is going to be your heart failure patients, liver failure. And then if you give someone excessive IV fluids. And what they mean by that is you would give them, if you bolus them with greater than 3 liters of fluid, you're going to have a problem. So does that kind of clear that up? Yes, no,
Yes.
maybe. Still thinking about it?
Yes, it does.
Okay. So that's completely separate, although we know SIADH can be a part of that. And when we're talking about from the DI standpoint, it's related to how we treat DI, not DI itself. But don't try to group all of your DIs and your SIADH into the sodiums, because you can have a sodium imbalance without those, as we just talked about through all of overall. So when would you consider using 3% sodium? What would the sodium level need to be in order to consider using your 3% sodium?
Lower than 120.
Lower, yeah, it'd be hypo.
So less than 120. What is normal?
For sodium, I got 135 to 145.
And that is true. Overall, that's going to be true. So when you have a patient, if their sodium level is 115,
That's hypo.
then we need to start looking at treating them with, 3% sodium. And if it's like 115 anyway, what is the patient at risk for? What complications are they at risk for?
Seizures.
Seizures, yeah.
Cerebral edema and seizures. So that's what we're trying to prevent, but seizures for sure, okay? And if they have low sodium levels, then you could potentially, and say for instance, if you had a patient that had SIADH, then, you want to monitor those sodium levels, because if they get to that critical level, then you may end up losing the patient. What is the first sign that you would anticipate a patient displaying if they have diabetes insipidus?
Severe dehydration, possibly lethargic, low blood pressure.
Okay. What are the normal signs that you would see? Let me swing it from that angle.
Sunken eyes, poor skin turgor, dry mucosal membranes.
Okay. Anything else?
Would they complain of a headache?
Would they complain? Would that be a part of their signs and or symptoms? Would they have a headache? I know this was, way back in the beginning of March, so about 30 days ago. All right, so.
Excessive vomiting? Not excessive vomiting, excessive urination?
It would be polyuria. So if they have DI, then they would have polyuria, okay? So they're gonna pee a lot. And why are they peeing a lot? But that's not the first assessment sign that you would notice. I'm trying to get this answer get to this chat. Hang on one sec. Okay, Nikki, she did say frequent urination. Okay, so they would have how much? 4 to 20 liters, 5 liters, what? When you say excessive urination, polyuria, what are you saying? You got this, guys. Come on.
Is there anything over 3 liters in 24 hours?
So, for sure, anything greater than 3 liters, 4 liters to 20 liters, they could technically put out. So that's the reason why you want to, another reason why they would be, kind of on the dry side, because we have a lot of urine. What would be the specific gravity of that urine? Would that be a high specific gravity? When I mean high, because remember it's 1 point, what is specific gravity? What is the number?
1.01 to 1.025, if I'm not mistaken.
So what would you expect someone with DI to have?
It'd be in the lower aspect because it's more of a just fluid coming out rather than electrolytes.
Exactly. So it's going to be really dilute, extremely dilute. So the specific gravity is going to be low. Okay. So we have polyuria, we have alteration in mental status. It could be dehydrated. They can have a headache. But the first things that you would probably see with those folks is going to be thirsty. So they may be irritable. They may have a decreased level of consciousness. They could have hyperthermia, excessive thirst because they've been peeing out a lot. But when you have somebody with DI, you should expect for them to have, urinary output of, 500 an hour. That's not abnormal. Usually DI can happen because of, a head injury. It could be congenital. It could be kidney disease. It could be related to pregnancy. So there's several risk factors, but head injury is a common one. So with that being said, things that you would need to report to your physician wouldn't be things that you would normally expect for them to present as. Does that make sense? You'd expect the specific gravity to be less than 1.010. Why? Because they have polyuria. Why? They're putting out 500, 600 milliliters per hour. They probably had a head injury. But do we want our patients to be confused? That's my question. Do we want our patients to be confused?
No, we don't.
No, because then that lets us know if they're confused that that sodium level is lower than what we anticipated. Does that make sense? So it's less than 135. So we may be less than 120 or lower than 120 when we start seeing things like confusion and they're really lethargic and not interacting with their environment. So those would be the things you want to report to the healthcare provider, because now you're going to need orders to give that 3% sodium. You're not going to just be able to pull that out and give it. And you need a large bore IV for that as well, right? But they're going to have dry mucous membranes. They're going to have poor skin turgor. They're going to crave cold water. They're going to be thirsty. So those are going to be your common signs and symptoms. But the one thing we don't mind them having some irritability, but we don't want them to be confused. We don't want them to be lethargic. That's a sodium that's less than 120 when we start seeing that happen. Okay. So those are things we would look at calling the doctor for. What medication, what's our first line treatment for diabetes insipidus?
The desmopressin?
Desmopressin, or DDAVP, or they could get subcutaneous vasopressin. So there's several things that they may use. They can also use for mild cases like the hydrochlorothiazide. That'll be the second line treatment for DI. And they have some others, so I'm just naming kind of the more common ones. They may be on a non-steroidal anti-inflammatory like indomethacin to help with concentrating the urine. So again, that's somebody with mild salt depletion for which that would happen, okay? But the DDAVP or the desmopressin it's a synthetic vasopressin without any vascular effects. So it has a long duration with few adverse effects to it. It can also be given intranasally, right? 1 to 2 times a day, either every 12 hours or every 24 hours. But what it's going to do is cause vasoconstriction. So we're going to use it cautiously, especially in our patients that have coronary artery disease. A type 2 diabetes mellitus medication can also cause hypoglycemia and increase ADH, which would be the chloropropamide. So there's several medications, or there's a couple medications that can be used, it may cause hyperglycemia, not hypoglycemia. Then we think about foods that we need to look at restricting or adding to the diet to help the patient. So that was on DI. On SIADH, here, we have water retention, volume overload, weight gain, high blood pressure because of the increased volume in the vascular system, tachycardia. What else? What else? What other signs and symptoms does the patient have?
Anorexia, nausea, and vomiting.
Right. So if you're going to study for SIADH and DI, then, you know, find some of the signs and symptoms that are common, or that will help you understand, not necessarily common, but will help you understand this disease condition better. Does that make sense? So in SIADH, we're going to have a decreased sodium level. We'll back that up, puppy. We're going to have a decreased sodium level, right? In DI, we're going to have a what level?
To increase type sodium.
So we have an increased sodium. Here you have all that polyuria. And whether it is up or down, we don't care either way, but confusion is, that's going to be an issue. So, you know, they have, those are things we want to pay attention to. The dilute urine. And this is just on the DI side that we just finished talking about. So I know that your text gives you all types of things, but on assessment, you know, they're going to have breathing problems. They're going to have a weakened immune system. I'm sorry, that's not what I meant to say. Not breathing problems. Well, they are going to have breathing problems because they're going to be dehydrated. But they're going to have tachycardia. So let me just take that off. Tachycardia, shortness of breath, low BP because of the fluid loss. So they're going to look dehydrated. So I would look at those types of things that you would see very quickly to let you know that there's an issue. You would expect their urinary output to be over 250 mils per hour. So, you know, it may be 500, it may be 600. So it's going to be high. Now, when you're looking at SIADH, I'm going to select all and delete. So when you're looking at SIADH, we're looking at something completely different. So now we're concerned, we're still concerned, you know, about mental status. So, you know, as that sodium level decreases, you know, less than 120 milliequivalents per liter, then we're going to start seeing more confusion. They're going to be less active or less alert. And now our concern here is going to be seizures. And we're going to be worried about, you know, other things, you know, cerebral dysfunction. So that's completely different than your DI. What is our main treatment for SIADH? It's our main medication that we're going to give.
I got written down loop diuretics.
They can give loop diuretics, but the first thing they will use the loop diuretics when the sodium levels are near normal and when heart failure is present. Otherwise, they're going to go with declamycin, which is demeclacycline. So that's the first one that they're going to give. And that'll be their long-term treatment. But if sodium levels are normal or near normal, and the patient has heart failure, then they're going to give loop diuretics. But when that sodium level is less than 120, then we're going to look at that 3% sodium chloride. So, you know, their urine osmo in this particular one is it going to be up or down?
It's going to be up.
Why up? And I'm not saying that you're wrong. I'm just saying why up.
Because the urine is going to be concentrated.
So if your serum osmolality, your urine osmolality, if that is up, then your urinary volume is down. So urine osmo, what's normal?
(200 to 800).
For urine?
Yes.
Okay. So this will be up because they're not going to be peeing like in DI, right? As I said, if you have increased urine osmo, then your volume is low. So here, the serum is going to be decreased. It's going to be less than 280. So it's going to be down. So they're going to do the opposite. So you go back to the notes from the urine and serum osmo and what happens in each of the conditions under both. Or it actually we gave a list of when would your serum be up, when would your urine be up and down. So we did that the first day. Is hyponatremia associated with high mortality? So if your serum sodium level is massively low, does this increase your mortality? Yes or no?
Yes.
Yes, it does. So it has an increase in mortality and morbidity. Okay. So what about kiddos? Do they ever get dehydrated?
Yes.
So if you get a child with a serum sodium level of, say, 115, what, you know, they're complaining of a headache, they have an alteration in their middle status. What should be the first thing you do? Forget about the fact that it's pediatric. What would you do if you just had any person that had a serum sodium of, you know, 115, 117, whatever? But it's less than
Obtain IV access as soon as possible.
before the IV access. What are they at risk for?
Seizures.
They're at risk for seizures. So the first thing we're going to institute is
Safety.
safety, seizure precautions. So anytime you're taking tests, think, you know, if safety is an answer choice, that's probably going to be your best bet. But if you have someone that does have that a serum sodium level of less than 120, yeah, whether it's pediatric or not pediatric, okay? So tell me again, what's the treatment for DI?
DAVP.
Okay, so DDAVP or desmopressin, vasopressin is what it is, because DI, they're missing that antidiuretic hormone vasopressin. What else?
The hydrochlorothiazide.
They can, if they have what?
The
That's going to be in mild cases. So we're going to give them something to replace the antidiuretic hormone that's missing. And that DDAVP is given sub-Q or intranasally. So you have options. But we're going to give it sub-Q primarily. What else? Since they're peeing out a lot, would they not need IV fluid replacement?
Yes, they would.
yes.
They will. So we need to consider that as well. And then we need to determine, because if we don't know why they're having the issue, then we need to figure out what underlying problem does the patient have to put them in, put them in DI in the first place. Okay. So, priorities, think about your priorities: safety. So, confusion, lethargy, seizure precautions. If they have it, that's the reason why we're going to, do some further investigation. If somebody does have DI, they're going to be peeing all day and all what?
Night. All
day and all night. So that means the person's going to have probably disturbed sleep, and they're going to be crankier, more tired, because they've been up half the night running back and forth, and all day running back and forth to the restroom. So that's those are some other things, especially the elderly too. That's going to be even more traumatic. Okay. So again, questions about that. So what is another way, without having DI and SIADH, that an individual can become dehydrated? What about if you're exercising?
What was the question?
So what electrolyte imbalance do you think you would have if you're doing a lot of exercising? So if you're exercising, you're sweating, right?
Mm-hmm.
Where did we see sweat fall when we just talked about some of this a little bit ago?
Hypovolemic hyponatremic.
Exactly. So the electrolyte imbalance is going to be sodium. Okay. So give me some values. Give me some values of an individual that's having vomiting. So type in the chat or where you, and I'm going to unshare screen. So type in the chat a set of vital signs you would anticipate as far as, not vital signs, electrolytes. Say you were doing a Chem 6. What would you expect those values to be? What, nobody has an idea?
I'm sorry, I had to step away. What was the question again?
So if you have a patient that has vomiting,
Mhm.
give me a sodium, a potassium level of what their electrolytes would look like.
Okay.
Sodium, or Chem 6 is like sodium, potassium, CO2, and chloride.
Potassium at 3, sodium of 122, all on the lower side. They're losing electrolytes and bile and gastric juices.
Exactly. So you would expect their sodium level to be less than 135. You would expect their potassium level to be less than 3.5, because honestly, that's going to be problematic. Okay. So their chloride level will be low as well, although we didn't talk about chloride levels, but that would also be low. But they would have hyponatremia, hypokalemia. Which acidosis would they be in? Or alkalosis, respiratory or metabolic?
Metabolic.
Metabolic alkalosis.
Metabolic alkalosis, that is true. Okay. All right, so you have a kiddo that has an acute form of diarrhea, or they have an acute form of vomiting, but they have moderate dehydration. How do we treat that?
Antiemetics in the PO challenge.
Okay. Does that do anything for the dehydration?
The PO challenge, yeah, if we're giving him, or seeing if he'll be able to keep down oral fluids if we give him antiemetics.
Okay, so let's take out the vomiting. So that way we don't have to worry about the antiemetics. So say it's diarrhea.
Okay.
Diarrhea.
So we could give them fluids.
Yeah.
Okay, for mild. Would that be the appropriate treatment for mild dehydration?
Maybe just like Pedialyte, start off with Pedialyte.
So we're gonna do oral rehydration for that, okay? Now the vomiting, that's gonna be a little bit more challenging. So yeah, we try to stop that so we can give them some hydration. But just stopping the vomiting you need to do more than just stop the vomiting. It would be no different than the diarrhea. But keep in mind, the more poo they put out, and we don't know how much they've put out already, then they're going to be at risk for dehydration, especially a kiddo, because they have a lower circulatory volume to begin with, correct?
Correct.
So it, you know, they just need to have 2 diarrhea stools that go through the pamper, and we may be in some big trouble.
Yep.
But when we're looking at mild, you know, mild dehydration, not massive, then, you know, we can start with some oral rehydration for them versus starting with IV fluids. Now, if it's severe, you know, okay, then we need to go full regalia. And, you know, there is no shame in that game. So don't forget about the pediatric dehydration in RECE, because they have different stages. But usually like that Pedialyte, highly sugary, by the way. Like, holy cow.
But yeah, I know this is real life and not test or whatever. But that's generally our go-to if there's just signs of mild dehydration or just a history of complaints of vomiting or diarrhea.
You're going
It's
in.
usually started. Is that better?
That's a little bit better. So go ahead.
I know this is real life and not testing, but our go-to whenever we have kiddos come in with either a complaint of diarrhea or vomiting or signs of mild dehydration, we almost always start with some ODT Zofran and Pedialyte or apple juice or whatever fluids we can give them, but Pedialyte preferably.
Right. And actually, oral rehydration would be Pedialyte. So that's not just, there's no difference. You're giving them some Zofran to help stop the vomiting, but the other piece is making sure you correct the dehydration.
Exactly. And the Zofran's the second line. We just start first, usually, if we can just keep down Pedialyte.
Exactly. And that's the bigger issue. So most people will, and my point is, you realize that you need to give something to stop the vomiting, but you forget that you also need to correct the dehydration, because if you only give them the antiemetic, you stop the problem, but you haven't fixed what the problem caused. Does that make sense?
Yes.
So I'm basically saying, don't forget to treat the problem, is, you know, the effects of the problem. So don't just stop the vomiting, treat also how it impacted the body. And a lot of times we get sidetracked because we get to thinking, we got to stop it. We got to stop this right here. And you do, but then you were like, well, okay, well, you get to treat the rest of it. So I'm saying treat the whole thing, not just one piece of it. All right. But yeah, that will be our first line of treatment for that individual. Okay, so should we, if an adult is dehydrated and their urinary output is less than 30 mils per hour, because isn't that normal?
Yes.
Okay, so since that's normal, if we're less than normal, give me some interventions that we should be doing.
Oral rehydration.
Okay. If it's less than 25, will that hurriedly increase the urinary output?
No.
Okay. So what can we give to increase urinary output?
IV fluids.
IV fluids. Okay. What else we're going? What else would be some assessment things we can do? For sure, the IV fluids. So we need to put in a saline lock and give some IV fluids to the individual. That is all true.
Assessment labs or assessment physical?
I mean, well, we're going to do a chem study on the lab, so we know that. But what other things we're going to do? So I'm just looking at the whole treatment, not just a piece.
Get a detailed history, see what may have led to this dehydration.
Okay, like it, keep going.
Detailed, of course, asking history of not just the complaint itself, but also oral intake and bowel movement and voiding outputs in the last, few days.
Okay.
Any medical history they may have that can be contributory and pertinent negatives.
Right. Okay. So say if the patient asks you for a soda, they want a Dr. Pepper. Because they're thirsty. It's liquid. Would that be in play or out of play?
Out of play.
Why?
I'd rather anything else.
So something is better than nothing? Is that what I'm hearing?
Something's better than nothing, but I'm sure we can convince the patient to drink something more helpful.
Okay, so really they shouldn't have any caffeinated drinks.
No.
So we can encourage them to drink, but we want it to be non-caffeinated. Because just think about when you drink soda, what's the first thing you have to do?
Drink more.
You got to pee. So do we want to now, put the patient at risk of further dehydration by giving them these caffeinated drinks?
No.
No. So we want to encourage fluids, but we don't want to give them things that's going to complicate. So sometimes something is better than nothing. That theory is not necessarily the best theory. Okay. What conditions would cause an individual to need a higher fluid intake? Especially in a kiddo.
CF.
Think smaller. Things that can happen to them. Well, that can happen to them too. So things like illnesses. What type of illnesses can?
Upper respiratory.
Upper respiratory infection, for sure. What else?
Any viral infection, really.
Okay. So if they have a fever, because you would expect that with an upper respiratory infection, or if they have something, like bronchitis, those things can increase their metabolic rate by 10% for every increase of for every 1 degree Celsius increase in temperature. So hyperthermia, definitely. If they're shivering, it's going to increase it 3 to 5 times. So we need to make sure we meet all of their fluid needs. So we need to make sure if they're a kiddo and they have a fever or upper respiratory infection, lower respiratory infection as well, any shivering, anything like that, then we're going to need to now increase their fluid intake, because they do have a higher or lower metabolic demand. Which one?
Higher.
They have a higher metabolic demand. So we need to make sure we're meeting those needs, and they're going to be burning up stuff real quick. And what I mean by burning up stuff, I'm talking about energy. They're going to be burning through. And what's their other metabolic tool that we need to pay attention to?
Respirations.
Besides respirations. What is the element that's part of their metabolic process that we need to monitor them for? when they're
Urine
stressed.
output.
Tachycardia.
Not tachycardia, because they're usually tachycardic already.
Level of consciousness.
Say that again.
LOC.
Not LOC. For kiddos, they have a high metabolic demand. And that metabolic demand is coming from the glucose. So when they're stressed, they will probably have hypoglycemia.
Oh, yeah.
So that's the other thing we want to monitor for. What populations of folks are at greatest risk for fluid-related health issues?
Older folks,
Okay, elderly and
kids.
pediatrics, which is what we're just talking about. So we want to look at their urinary output. We want to look at the color, consistency, the odor. We want to consider, depending on how severe the dehydration is, that they're going to, need an IV. We're going to encourage them to drink fluids. Look for sunken fontanelles for our pediatric patients. Which fontanelle, anterior or posteriorly?
What age?
We'll say 12 months old.
Posterior.
You guys agree?
Yes.
No.
So the posterior closes at 6 months. So 4 to 6 months, the back one's closed. The front one stays open. The anterior stays open up to 18 months. But we can use it to look at volume status, because if it's bulging, then that lets us know that the patient has an increase in ICP. If the patient has a bulging fontanelle and a fever to go along with it, and they're within 18 months of age, then that would be meningitis, and then sunken would be indicative of dehydration. All right, so let's switch gears and talk about fluid volume excess. Give me some signs and symptoms that you would notice in fluid volume excess.
Edema.
Bounding pulse.
Weight gain.
Say that again.
JVD.
JVD, okay.
Weight gain. Edema.
Edema, so crackles, rails, what else?
Bounding pulse.
A bounding pulse. Oh, yep, that would be true. What is the condition for which, what other conditions, and I don't think we talked about these. So say if your patient was a drowning and they were in salt water.
That's no bueno.
No, that is no bueno. So they were in salt water. Okay, so I'm gonna share my screen. Take off this here. Okay, so they're in salt water. Okay. And what would you expect? How would this affect the lungs?
Lots of edema.
Why?
Salt's pulling water from the vascular space out of the capillaries and into the alveoli. That's going to cause edema and possibly loss of surfactant.
So they're going to have, so if they have edema in the lungs, what is that condition?
Flash pulmonary edema.
Well, it's going to be pulmonary edema. If it's fresh water, then what would they have? So here they're going to lose surfactant. And therefore the lungs won't expand. So if the lungs don't expand, they're going to end up now what they call a aspiration in the lungs. So we have this two different pieces. So fresh water, they're going to lose the surfactant, and then they won't be able to expand the lungs. That's freshwater aspiration. Salt water, we're going to end up with pulmonary edema because salt water follows salt. And they may end up with acute respiratory distress syndrome because of hypoxia and all those things. Other issues they could have is hypernatremia. Okay. All right, so when we talked about folks in heart failure or fluid volume excess, what were those numbers that we talked about, like as far as weight gain that we needed to be mindful about?
Greater than 2 pounds in a day.
Right, so yes, we don't want them gaining more than 2 pounds in a short amount of time, right? 5 pounds in 3 days, would that be good or bad?
Bad.
That'll be terrible.
Unless you're quarantining onto the refrigerator every 5 minutes.
You got to think about other stuff to do.
Right.
So you can't be thinking about drinking. That would not be a good thing. Okay, so folks with, because this is part of electrolytes, that have renal failure, chronic kidney disease, and they're getting peritoneal dialysis. What if it doesn't drain appropriately? So say, for instance, it starts to drain, but it's kind of trickling along and it's not a steady flow. What could you do to treat that? What would be your interventions for that? What could you do? You got this, guys. Come on. So what do you think the problem is? Do you think it's out of place? What?
I mean,
just think it through. You have a catheter, it's in the patient's, peritoneum, and they're doing dialysis, so you have the bag that comes from the top, right? So it's putting in dialysate, but what's coming out is trickling out. So is that normal?
no.
Okay, so it's not normal, but we know it's in. But what could potentially be the problem?
A clog?
Okay, it may be. So here's, the person's belly, the sorry belly, and then you have the tube that's going in, right? And so what's coming out here to the bag It's just like, you know, do, 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 do. So maybe what's on the inside, you know, maybe a little mesentery, whatever, maybe it's just wedged up against there. It's not necessarily clogged in a way, but it's definitely preventing flow. So maybe have the person reposition themselves to facilitate the drainage better. So just because you stick the, you know, you have the tube and everything, it doesn't mean that it doesn't get wedged up against some of the structures internally. So it's kind of like your central line. If you have a central line and it doesn't necessarily, you can get some blood flow back, but it's not coming back like it, you know, it's not, there's not an ease to it, then, you know, you can have the patient cough, you can have the patient turn. So you kind of reposition and see if that helps facilitate, you know, the catheter, you know, becoming separated from the structure that it may be up against. So those are some things that you could, you know, you could look at doing. And we definitely know we don't want the drainage to be what?
Cloudy.
Cloudy. So we don't want it to look purulent or anything of that nature. Okay, so things you want to check with your dialysis patients, whether they're hemodialysis or whether they are peritoneal dialysis. What are two things you want to check to make sure that your patient is on point?
Wet weight and dry weight.
We want to check the weight, and we want to monitor what else?
Blood pressure.
Blood pressure, because remember, all that fluid shifting that's going on is going to be problematic. Okay. What how would you know they have an electrolyte imbalance?
They have like hyperkalemia.
Especially if it's you know, you have a renal failure patient and they have an increased magnesium. How would you know?
The blood pressure will be low.
Okay, besides blood pressure. And we just talked about this on.
The decreased tendon reflexes.
Okay, so deep tendon reflexes will be diminished. What else? What else besides the deep tendon reflexes for the MAG? So when we did hypermagnesemia, right? We looked at in high magnesium levels.
Like chest pain or cardiac arrest?
So we're looking for, like, how would the patient present?
Oh, okay.
The first thing, they're going to be really weak, profound weakness, tired, have the decreased or absent deep tendon reflexes. They could have a low BP, but if they're weak, they're going to be lethargic, right? So they're going to be tired and lethargic. Everything's going to be slow. Heart rate slow, you know, respiratory arrest because of the weak skeletal muscles. Their breathing will be impaired. They could go into cardiac arrest. But the first thing that you would be noticing is that your patient has an alteration in mental status. So think about your assessment pieces for your patient. When you first see them, hey, my name is blah, 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 I'm going to be your nurse today. And if the patient seems, you know, tired and, you know, can barely hold their own head up and they're extremely weak, then, you know, they may have too much MAG. Remember that lethargy, we need to think about patient safety. So, you know, just because it's a renal failure, and this happens in renal failure patients, because why? They can't clear anything. So if we give a person magnesium, so, you know, for some reason, we need to be checking their mental status and we need to be checking their deep tendon reflexes to see, hey, what's going on? Making sure we're not giving them hypermagnesemia. On the other end of the spectrum, when they have hypomagnesemia, they still have an alteration in mental status because the magnesium is too low, right? But now we have irritability, we have, you know, tetany, we have all of those things. So it's the opposite. But if we're given a magnesium for a low mag, then we need to be looking at level of consciousness. It'll be diminished, the reflexes diminished, blood pressure diminished, respirations diminished. So we need to be looking for the signs and symptoms of, you know, worst case scenario of giving them too much mag. Usually patients with a low mag are your drinkers, because they have anybody with poor food intake. You know, but drinkers are usually our biggest culprits with low magnesemia or hypomagnesemia.
They're still checking on those bones. Can you get here?
Speak up for me, please.
Sorry, I was talking to my daughter.
All right. So what is Trousseau sign and Chevestek sign? What do they measure?
They measure the neuromuscular status.
They're seen in hypomagnesium as well.
Okay, I just had to wait for the phone to stop ringing. I wasn't going to get it anyway. Okay, so what are the two electrolytes, or there may be more than two, but magnesium is one, hypomag. What's the other one?
Calcium.
Calcium.
So we see that when the calcium levels are up or down?
Down.
Low.
Low. Okay, so less than 8?
Yes.
Okay. And then how do you measure Trousseau's?
You put a blood pressure cuff on the upper arm and look for flexion of the wrist and the hand.
Right. And what about Chevestek sign?
You tap the cheek and you look for them to like clench up their mouth.
So lips and nose is what you're gonna pay attention to.
Lips and nose.
Hypokalemia, when your potassium level is too low, what signs and symptoms would you expect to see with hypokalemia?
Low blood pressure, increased urine output, decreased heart rate. For hypokalemia, you're going to have a decreased heart rate or bradycardia and decreased urine output.
But they're going to have loss of urine.
I meant to say, yeah, increase in urine output.
Yeah.
And an increase in heart rate for hypo.
Right.
So
with hypokalemia, everything's going to be low except for that volume, right?
Right.
Of urine. So lethargic, their respirations will be low and shallow, their cardiovascular levels, that's going to be a problem because I have cardiovascular changes. And the leg cramps, low BP, low heart rate, limp muscles. We want to watch for magnesium levels because K and mag like to play together sometimes. We're also going to monitor for the glucose, the calcium, and sodium because they're part of cell transport. But when we have somebody that have low potassium, we also want to see if they're on what medication?
Digoxin.
Digoxin, because the decreasing potassium can lead to digoxin toxicity. So we want to kind of follow that full circle for an individual, for a client that may be on DIG. We need to monitor those potassium levels. So if their potassium level is less than 2.5, then we're going to do a potassium infusion. If it's between 2.5 and 3.5, then they usually give oral supplements and, you know, look at foods and things of that nature. So what about hyperkalemia? What are signs and symptoms of hyperkalemia?
Arrhythmia.
Decrease urine output,
So urinary output's low or absent.
decrease heart rate,
Okay. Their blood pressure can also be low. Their pulse will be low. That's that cardiac irritability. But if they have hyperkalemia, what's going to show up on the ECG?
elevated T wave,
So tall peak T waves, and then with low potassium, they're going to have what wave will be introduced?
U wave.
A U wave. So urinary output's low, muscles are low. They have early signs of muscle twitching and cramping. A late sign would be profound weakness. So for that individual, you know, they have the, that would be hyperkalemia with the tall peaked T waves. Okay, so when's the best time to give somebody a diuretic?
In the morning.
In the morning. Because if you give it to them mid-afternoon, they may be up till midnight peeing, right? And if you give it at night, you know for sure they're going to be up all night peeing. But when you give them a diuretic, you also want to monitor potassium levels. So, you know, because that also goes out with the urine. And how do you know that a diuretic has been effective, you know, if you're treating a patient with volume overload? What would you monitor to know that that volume overload is being addressed?
weight,
Besides weight. Because if you give somebody a diuretic, are you going to measure them every hour?
Eyes and nose.
You're going to monitor INOs. So its job is to increase urinary output, and we're going to monitor those INOs to see if we have too much output or if we don't have enough output. So if, you know, we can look at listen to breath sounds and heart tones, that would be more important to assess if the client was receiving furosemide or Lasix for heart failure. So just monitoring somebody for fluid volume excess as a whole, we're going to look at the INOs. We want to see if they're actually peeing off this excess fluid. So does this make sense? It's starting to kind of wrap your mind around it a little bit better than prior?
A little better, yes.
And then you did receive the information from Miss Gordon, and I know she said she was going to ask you guys to contact her if you had questions. So I'm presuming that you didn't have any, because I haven't heard from her to say that, you know, you guys had questions. There will be some math on this exam. So, and don't forget about your functional ability. You know, what can the patient do? So doing, you know, an assessment, knowing the stages of what kiddos can do. For example, should a kiddo know how to run? What age would that be?
Two, 3, 18 months.
At least 2 years. Those terrible twos. Babies are running around every doggone where. So if the baby don't know how to run, you say run, and the baby is just looking at you like, what does that mean? Is that normal? Would that be normal? I guess is what I'm saying.
For a 2-year-old to run? Yes.
So basically, as kids grow and as adults grow, you know, how do you know that they have a developmental delay? So by 2 years old, they should know how to run. They should know how to jump in place. They should know how to ride a tricycle. They should be able to stack blocks, at least 4 of them. They should know how to throw a ball overhand. They should know how to scribble. Do you see what I'm saying?
Yes.
They should be able to use words like me, like you. They should know how to, you know, at least put some clothing on. They may not get the color pattern right, you know, but Granimals works really well. However, by 4, these are things that they should actually know how to do before they go to, you know, to preschool. And if they don't know how to stack blocks and they're 6 and 7 years of age, that's a developmental delay. Okay. So, you know, as you go through the stages for both kiddos and adults for functional ability, it's, you know, there's certain things they should be able to do that's appropriate. If they can't really hold a spoon correctly by 3 or 4, that's problematic. Because they should, at that point, know how to feed themselves. Would that be a fair assessment?
Yes.
Okay. So there's milestones that you pay attention to. You know, potty training, that's a little bit tricky, but by 3 years old, most kids should be potty trained. For sure, letting you know they have to do a number 1 or a number 2. They should be able to at least get to that piece. Will they, you know, you get them to wipe themselves really well? No, that happens over years. So, but, you know, by 5, they should know how to wash their hands, dry their hands. They should know how to eat, use the bathroom. Those are things that they should know before 5 years of age. So if they're 6, 7, 8 years of age and they're still on that struggle bus, then that's a developmental delay, whether they have an internal problem or their environment was not conducive of the learning. Okay. On the other side of that would be your elderly folks, you know, looking at things that they can or can no longer do. That's also going to be the other piece of functional ability. So there's primary and secondary functional ability. What's the difference? What's the difference between primary and secondary functional ability?
Would primary just be due to direct aging and secondary be to an underlying cause like a comorbidity?
Correct. So if they have like a stroke, that would be a secondary functional ability, but primary is when the ability to perform a particular function has never been developed. Secondary functional ability is when somebody has they have a functional ability problem in which that occurs after that ability has been achieved. So you know how to comb your hair. You learn how to comb your hair, but then something happens to you that you can no longer comb your hair. That would be secondary functional ability, where that would be the deficit in it. So if you learn to use your extremities, which you do, you learn how to write. And then say, for instance, you have a problem like an arm injury, and now you have decreased use or you can't use it anymore, then that would be secondary. But if you never learned how to swim, that's a primary functional ability issue because you never learned it in the first place. You just put your feet in the water. Does that make sense? So you really didn't lose anything per se because you never gained it in the first place. So what about your patients that have conditions that impact their ability to, use their hands or use their legs, where they can't brush their teeth or they can't walk or things like that? How do you approach those folks? What should you be doing with those individuals? Well, you know what, Mr. Green, you had this spinal cord injury, and because of that, you cannot use your legs anymore, so don't even try.
Don't you encourage them to do as much as they can that was like normal to their like normal activities before that happened?
Absolutely. So last November, I met a gentleman. He was 20 something, barely 21. But when he was 16, he was a motocross rider, had a traumatic spinal cord injury. And they basically told him he would not have any use of his legs or arms. And most people, when they hear that, they would just like be, devastated, which he was. But he was like, I'm going to learn how to use something. And even the nursing staff, which, that was kind of shocking, was, well, you've had this traumatic spinal cord injury and you're not going to be able to get full function of your legs for sure, arms maybe, but they had literally given up hope. And the kid said, no, I'm going to try and learn how to use as much of this as possible. So he flipped the script on them and made them start, doing that active passive range of motion while he was in therapy or treatment, et cetera, et cetera, et cetera. And this went on for several years. He was in a motorized scooter. However, he was able to use his arms and hands and fingers. He was able to, he had feeling in his legs. And his goal is to keep working on it to stimulate the neurons to hopefully be able to walk. Now, he may end up doing it with assistance, but at the end of the day, he was, I want to try and learn how to do as much of my care as I can. And I need to start now to start training my body to do those things. So he just didn't lay down and give up. But he is driving a car because they can outfit vehicles for folks with those types of injuries. And so he goes, it was a little terrifying trying to learn it that way, but at least he can drive and go where he needs to go and then, move on around. So you always want to make sure that you give them choices about their care, and you try to get them as much functional use back as possible. You're not a miracle worker, you're not a magician, but you're definitely going to advocate for the patient and not just say, well, you know, if it was me, I'd just give up and say, forget about it. But, you know, you just can't do that. You need to be a little bit more vigilant in that nature. Does that make sense?
Yeah, you always have to stay positive.
Exactly. So what about, you know, our kiddos that are, you know, substance abuse, or their parents use substances while they were in utero, especially, you know, now they're having drug withdrawals. How do we treat those little kids? Scream at them?
No, never.
Shut up! What do you do?
Well,
Because
you
those
need-
babies are very difficult to manage. But what can we do to provide comfort for those individuals? What
Give
type of
them lots of
environment?
TLC.
What was that?
Give them lots of TLC.
Yeah, lots of tender love and care, but how would you do that?
You can swaddle them.
Yep, you can swaddle the infant. You want to swaddle them very tightly.
Give them a
and
pacifier.
handle them gently. So basically, you know, and not just only your drug withdrawal babies, but even a regular baby, when they're you know, small, they want to be swaddled or wrapped in the baby blanket really tightly. They actually find it comforting. It's almost like a comfort blanket. Those weighted blankets that people use to help with anxiety and things like that. So, you know, we can do low lighting. We can do quiet environment with little stimulation, pacifiers, soft voices, small frequency feedings, rocking the baby. So, you know, when they're really agitated. So those are things that you could do for any baby, for that matter. But for them, they definitely need that tightness, to feel comforted. So how did your CPP exam go today?
Good.
Very well.
Cool beans. So there'll be some math questions. Do you have any questions on how to solve math problems?
Yes.
What kind of math?
Probably very similar to what you experienced in the CPP exam.
Okay.
You know, how to do milliliters per hour, how to do, you know, how many milliliters would you administer, you know, those types of things.
Okay.
Does that make sense?
Yeah.
Okay.
But not like drip rates or anything, because we just learned that today.
Not drip rates, but more of, you know, if your patient weighed 11 pounds and you needed to give whatever, you know, fluids, or if you needed to give a medication, so what would the milliliters be? What would the milliliters per hour be? It's more of that kind of stuff. It should be something
Okay.
very, you know, simple, nothing complicated.
Okay.
She's like, not drips, we just learned that. So stay tuned. That may be on exam 4 though. That would be fair game.
Okay.
My advice to you guys would be to find one method that works for you and stick to it. So if you are a dimensional analysis person, do it. If you are a formula person, then stick to it. If you are a ratios and proportion person, stick to it. Don't try to learn 600 different ways. There is no policy to say that you have to learn it the faculty members' way, the way they do it. There isn't. You need to learn it for yourself. So if you find any of them to be too cumbersome, then you know what? Find the one that's not cumbersome for you. So there's no rule to say you have to have it, you know, do it this way only. There's more than one way to solve a math problem. Any other questions for me? So don't forget about your coping cognition. We got all your F and E. Functional ability. Trying to see if there's anything else. Math we talked about. So other than that, I mean, I think it's basically you guys kind of knocking down some of the studying. Right?
Yes.
Okay. Just wondering. So do you have any other questions I can answer beforehand?
No, I think you've done a good job covering it. I just want to tell you thank you for your time.
Anytime. And it's kind of a crazy week because, you know, you were off for 2 weeks. I couldn't reach out to you and say, hey, let's meet on Zoom because we were told we can't contact the students to do any activities. So that's why I said we can do it on Friday, and it made it a lot more simple anyway because you guys were taking that CPP exam. So
yeah, that CCP exam was very basic and straightforward.
okay, well, cool beans. All right, guys. Well, we can wrap this up. I'll post it, and so that way, if you need it, then you got it.
8:30 Monday, Tuesday.
I believe that's what Mrs. Johns have up there. But it's going to be, remember, you're at home. So just, you know, I'm not saying lock up children or anything like that, but just make sure that you have no interruptions and you can make that place as quiet as you need to. You know, you don't have to worry about the trains and stuff going by. Or people entering or exiting out. So you don't have to worry about any of that. If you know, you can't go to the bathroom, so don't do that. But, you know, you got to stay in the room, go to the bathroom before the test.
Okay.
So Ms. Hudson,
Yes.
I have a question. It might be dumb, but I want to ask anyways. So for this test, will there be some growth and development still? Because I know the last test we had it.
Yeah, it's about the functional ability though. So
Okay.
that plays a role in the growth and development. You're looking at, you know, what things should they be able to do. So looking at that developmental age, this is where they should be. So now they're saying, hey, we're at this age, we should be doing these things. Does that make sense, Ms. Steph?
Okay.
So yeah, this, you know, make sure you have everything of what you need. You don't need to pee, you use the restroom. You know, they may do a 360 view of your room, so be ready for that. You know, take your test, read it, you know, think through it, and you won't be able to use like scratch paper at your desk or wherever you take the test, but there'll be a whiteboard provided for you that you can use with a calculator, so you can do that.
So Monday is the test, and then Tuesday, are we having lecture at 8:30 or is that at 10?
No, we're going to start early because we have a lot of cardiac stuff to get through, perfusion, and then GI is very small. It's not a lot, but we have to do basic ECGs, hypertension, heart attack stuff, heart failure again, peripheral vascular disease again. Trying to remember all the stuff. It's like 6 different pieces to perfusion. And then we have the elimination. So they took out Crohn's, so we don't have to worry about that. But there's other stuff we need to talk about that. But if you need a break, we can start at 10. I'm okay with that because I think we have 3 weeks before we need to finish out, right?
No, we can start early.
So, all right, 8:30, I'll set it up. So we'll see you then.
Okay.
Do the best you can.
Thank you.
You're welcome. Bye-bye.
Thank you.
Bye-bye.